Okay. Can you hear me? All right. So welcome, everyone. I'm David Dorr, the Vice Chair of the department, and this is an Informatics Discovery Lab lecture, which feels a lot like the Department of Medical Informatics and Clinical Epidemiology lecture, but it's a little more special in some way. Our focus is really partnering with industry to really figure out next generation solutions to real problems, understanding them, working on them, developing them in partnership with industry. And I'm kind of lucky today because I have my good friend Viet Nguyen coming to talk from a company, Systems Made Simple, about being a CMIO. And Viet is really somebody that I respect, and we actually trained together in Utah many years ago as medical informaticians. He coming en route from getting his MD at University of Utah and then going and doing a medicine and pediatrics joint residency in Cincinnati and being a chief at Cincinnati Children's, and then coming back to join me at the University of Utah Informatics. And so it's really useful, I think, for us to think about the differences in our careers and where we've ended up and how much good we can sort of do in different aspects, I in academics, he in industry, of the informatics world today. It's really something pretty impressive, I think, that informatics has really gotten to the point where industry really appreciates and needs people like Viet, who I admire so much. So with that, I will stop and let him go ahead. Thanks.
Thank you. Thank you very much. Dr. Hirsch isn't here, but I want to thank Dr. Hirsch and the department for inviting us to come visit. I'm here today with Rob Sachs. He's the Chief Technology Officer for SMS, and here to talk to the IDL group about ways we can collaborate and work together and bring that academic commercial collaboration to fruition and bring value into healthcare IT. So I'm not big on giving like presentations where next slide, read the slide. I'd prefer this to be a discussion because personally I actually do better having conversation with folks than talking to them. So feel free to stop me at any time. And what I'm going to just do is to use these slides to help kind of guide our conversation, to give you a little bit more kind of perspective on where I came from. After the informatics fellowship in Utah, I had to make kind of career decisions, as we all do, and to decide, okay, now I have this informatics training, and I really like it, and it's really interesting stuff, but I was trained as a doctor, and I'm a pediatrician, I'm an internist, and I really should be using some of these skills. And so I started a practice, which I don't really recommend anymore to people. I started internal medicine and pediatrics practice with a partner, and we opened it in Park City, Utah, which is a fabulous place to work, beautiful scenery. And so we provided inpatient and outpatient care. And a few years after we started the practice, Intermountain Healthcare, which is a vertically integrated delivery network in Utah, opened a community hospital there. And so we had this outpatient practice, and then we became the inpatient hospitalist. And so half the nights of the month, I was on call as a hospitalist. And I was working 3 days a week in the office, and then 2 days a week as a clinical terminologist for a contractor who was doing work with the Veterans Administration. And after doing that about 5 or 6 years, 7, 8 years, I thought to myself, wow, I'm working like 2.5 FTEs. And I was pretty much on call. Whenever I was on call, I was getting called in. And so I thought, okay, you kind of have to think to yourself, what do you love to do, and what's paying the bills? And I really love taking care of patients. I really enjoyed taking care of patients. But what I realized was that quality of life was going to come from doing informatics more full-time. And so I had the opportunity to talk to SMS, who is a very rapidly growing healthcare IT company, about working with them. And I'll tell you a little bit more about that. And so I've been with SMS about 19 months now as their CMIO. It's been an interesting 19 months. So as with a lot of things I do, when you need a definition, a good place to go is Wikipedia. So their definition for a CMIO is a healthcare executive, which I agree. Generally responsible for health informatics, I agree. Platform, depends. Working with clinical IT staff, I think in general that's true, to support efficient design, implementation, and use of health technology within a healthcare organization, or at least in my case, for healthcare organizations. So looking around at other folks who are CMIOs, and as part of prepping for this, I interviewed a few of my friends who are CMIOs. We looked at the settings where CMIOs work, and the most common ones are ones you're familiar with that work in hospitals or for hospital systems. And so I wanted to introduce two other areas which some of you may not have thought of where CMIOs can be have a place. And one is with a systems integrator, and the other are with product vendors. And before I joined SMS, I had no idea what a systems integrator is. Does anyone here have a sense of what a systems integrator is? Okay, me neither. So a systems integrator is a kind of a term used for large companies that do work either implementing software into a system or developing software, and they're generally thought of in the federal space. So Hewlett-Packard, although they make printers and other technology, they're a systems integrator. They can be hired, and they try to win contracts to develop software, and so do we at SMS. There are several of these large system integrators, and when I joined SMS, they were just awarded a contract vehicle called Transformation 21. It's called T4, and it's a VA, Veterans Administration contract vehicle, and there are only 15 prime contractors on that vehicle, which means that the 15 had to be pre-qualified to show that they had the capabilities and the background and the knowledge and the capability to win and carry out contracts for the VA. And SMS was one of what's considered a service-disabled, veteran-owned small business, which is a distinction similar to minority status or small business status or women-owned status. And so they were looking to grow, and that's one of the reasons they hired me on, because they knew that with this contract vehicle, there would be a lot of work doing healthcare work for VA. So product vendors, I'm sure you're all familiar with. Your EHR vendors, device vendors, other software, as well as professional services. And then, as we mentioned, the healthcare provider organizations, not only the ones small community, rural community, but healthcare systems, as well as we have to consider the federal healthcare providers, Veterans Administration, Department of Defense, Indian Health Service. So they're all providers. So in my role as a CMIO for SMS, when I went in and interviewed with the executives, they really didn't know what exactly a CMIO would do for them. So in preparing for the interview and discussions with them, I kind of laid out a four-pronged approach that I did. And a friend, a colleague with another large systems integrator, he had a similar kind of view. And so I looked at who would be my audience that I would be interacting with, and how could I be of service to them. And so the first prong were the executives, the folks that own the company, because SMS is still a privately owned company. And in that area, I'm an advisor. I work with them to help them develop their healthcare IT strategy. And what does that mean? It means looking at the things that SMS does well, the things that SMS wants to do, the healthcare, their existing market, which right at the beginning was the Veterans Administration. 95% of their business was Veterans Administration. Where they want to see their market grow into other federal healthcare providers. Now we work with the Department of Defense. Now I do some work with CMS, the Centers for Medicare and Medicaid Services. We want to grow that into Social Security, and then ultimately, ideally, into the commercial area. But how do you do that? You have to know what you're capable of doing and what the market needs, what are the market drivers, and how do you develop those capabilities within the company in order to meet those needs and provide a service or value to your customers. The second aspect is that I work directly on projects. I work on a contract for Standards and Terminology Services for the VA, which works to maintain their codes, which is what I actually had been doing for about 10 years, as soon as I finished the fellowship. So it wasn't terribly new, which was helpful because when contracts change, you need people who know what was happening on a contract to help in proposals and such. I work on that. I also do some work for CMS to help support their S&I framework, the Standards and Interoperability Framework, on one of their initiatives called the Electronic Submission of Medical Documentation. And I provide subject matter expertise in informatics, and particularly in standards, CDAs, kind of technology we're working with. I spend a fair amount of time in business development, which means I go out and I meet with clients and customers, try to understand what their issues are, what their goals and their directions are, how SMS might be able to, with our capabilities, support them. It's a challenge because you're out there, you're working with clients, but when you're in the federal space, they can only talk about so much, and you're trying to get an understanding well enough so that when they release a contract request, you can respond in a knowledgeable way and formulate a solution for them that recognizes the environment they're working in, the issues that they have, and how your company will provide a well thought out solution. And so that's the other part of business development I do, which is proposal writing, which I never really thought I would do, but turns out to be a fair amount, which is taking one of these contract requests. They have a problem. They say, address this as a software approach. And so I work with a team of writers and account managers and try to give them the healthcare perspective. So if it's software like the emergency department information system for VA, my understanding of the emergency room helps them understand how that software needs to work and how it needs issues that need to be addressed in order to enhance that software. And then lastly is activities like this, outreach. So it's all the outward-facing things, being part of AMIA, going to HL7 meetings and understanding standards development, going to HIMSS and meeting with potential partners, trying to understand technology. So those are kind of the 4 areas that I direct my time, and any given day I can slide it into one of those slots. So, questions so far? Yes?
Break that down in any kind of percentage? Does it sort of stable percentage, or does it vary all over?
It varies. The projects, I'm pretty steadily doing about 20 to 25% of my time. The STS project, the standards, VA standards, it's in a sustainment, so I just need to provide some backup if they have issues. For the ONC work, it's pretty regular conference calls and then work outside the conference calls to prepare presentations for the discussion with the wider community. Business development, pretty easily 50% of the time. Working on proposals, meeting with potential partners, evaluating potential partners' technologies, and seeing if it's something we want to know more about, so that if we encounter an issue that the customer brings up, we can say, oh, we have a partner that has a technology we think can meet your needs. So understanding partners' technologies is a fair amount of time. Other questions? Okay. So commercial vendor, I only know of a handful of CMIOs in this space, but it's very focused on their technology. And in the same way, my first one, the Systems Integrated Healthcare IT Strategy, a vendor has to have that as well. But theirs is focused on their product, say an EMR. They have to know their markets. They have to know what direction the company is going, what the market is looking for. And so that's where the CMIO would provide their input. For an EMR vendor, the meaningful use is a major driver right now. So if an EMR developer doesn't understand meaningful use criteria, they're in trouble. And if they don't have someone who can translate those meaningful use criteria and standards down to the application requirements for the developers, they're in trouble. So CMIOs could be involved in product development, as well as sales to a certain extent. Promoting the product to hospitals or end users, and then providing product support. So if you're an EMR vendor, you might, a hospital may have issues with, say, document templates. You might have clinicians involved. And this is not just the CMIO, but also other health, clinical informaticists who understand these. Because a CMIO can work in isolation, but probably isn't as effective working in isolation. And I'll talk about a few other things. And then there are CMIOs for companies that do consulting, too. They'll go in and help a hospital as they're doing their initial internal evaluation of their infrastructure and their resources in order to help them prepare for purchasing new software applications and such. So this is the area where you've probably seen the most CMIOs working in hospitals or in hospital systems. And again, healthcare IT strategy. CMIOs, in my view, put pieces together. Put the clinical with to the extent that they're technologically minded, the technology together, and then understanding the healthcare environment and understanding the drivers and how those drivers affect the business or the corporation that they're working for. So they may be involved in IT evaluations, which would be a small rural hospital saying, we need an EMR, what's our hardware, what's our networks, what's our culture? Are the docs, are they going to be enthusiastic? Are they going to be supportive? And then what are the things we need so that we can then put out a request for proposals for an EMR, and then how do we evaluate these EMRs? So a CMIO is a good person or a clinical informatics person to help lead those evaluations. They're going to be an integral part, and plenty has been written and word-of-mouth discussions about implementation. And there are lots of aspects of implementation, including how the institution is prepared, not only physically with their networks and their infrastructure and their software, but the huge part is culture and change management, and and how successful can you be in being advocates, and how well did you plan on rolling it out? It's a huge part of the CMIO's role. I haven't done it personally, but I've spoken with some folks, and it can be a big challenge. It can be a huge challenge because you have to work with a lot of docs, and as a doc, they can be difficult. So even following implementation, providing support, ongoing support to the clinical staff, understanding their needs, talking to them, and then being a liaison to the IT staff, so that you're a bridge, because the clinical staff has some idea of how the technology is supposed to work and how it either helps their workflow or impedes their workflow, and we have to be able to communicate that to the IT staff so we can provide support. But we also want to be able to have the clinicians recognize that there are limitations to all technology. It's not a panacea, and you can't do everything. I see also the CMIOs working on quality improvement, taking the informatics skills and understanding data and how data works in order to support improving, doing reporting for quality and things like meaningful use and compliance and JCO. And then one of the big topics in discussion with pretty much all the CMOs I've talked to is clinical duties. It's a challenge. I think coming in as a CMIO, there's several different paths. There's the path where you're a clinician and you have a good base of clinical work, or you have a good base of informatics work into becoming a CMIO. And the challenge is, if you're at an institution and you're a clinician, the challenge is you have to have your what's the word I want? You have to have demonstrated that you know how to practice medicine. You have to have credibility. And that credibility comes from having practiced medicine for a long time. And in there, you have to put in that you have some credibility as doing informatics. And it's really hard. And I think that's why the early CMIOs were the clinicians on the medical staff who were also very tech savvy, who kind of learned the informatics because they got involved as a physician champion of technology and in implementation. And then because they were part of that medical staff, they grew with that medical staff, they earned that respect. But as a CMIO, one of my friends at another academic institution, he started out as that way, but he continues to do hospitalist work, a week a month. That's a lot. It's a lot of work, but that enables him to be able to say to the clinicians, not only the physicians, but also the nurses, I'm using the same system I'm asking you to use. And so there's a lot of credibility there. The challenge is, when he's on service, he's working 8, 10, 12 hours a day, and he's really not available to the administrative staff because he's taking care of patients. So that becomes part of the challenge. And honestly, that's the challenge I'm facing at this point, too, because I was practicing full-time till about 18 months ago, and then practiced part-time as a hospitalist for about 12 months. And I'm at the point where I have to decide. Because my company is not a hospital, I'm not going to get extra credit for doing clinical work, so I have to find that separately. And then you get into the discussion, which I think is always important, about the work-family balance. So it's going to be an ongoing discussion, because we would need, if a hospital and the CMIO, or the clinical informaticist, values that clinical time, they'll have to fight for it and help people understand. And then one of the other personal things is I'm an internist and a pediatrician, and it's hard enough to keep up with one or the other. So now trying to keep up with both of those, as well as what's happening in informatics. There's only so many hours in the day. So those are some things to consider. A topic that comes up very, very frequently is, who does a CMIO report to? So it's a sea of Cs. So you have the chief executive officer, you have the chief information officer, you have the chief medical officer, who's invariably a physician. Then you have the chief operating officer. And then you have other C folks in there that I didn't list because they're relatively new. Not the chief nursing officer, but you may have a chief nursing officer somewhere in there. You may have a chief quality officer somewhere in there. And so the challenge is, the relationships with each of these folks comes with pros and cons. If the relationship directly reporting to CEO is great, assuming the CEO understands the value of the CMIO, can have the discussions, and you can have influence and such. But if you report to the CEO as a CMIO, and the CIO reports to the CEO, there's the possibility of conflicting goals. And that's why it's so important for the CMIO to be part of the executive staff, to have everyone has that shared mission, vision, and strategy and execution. And if you're reporting to the CEO and you have a budget, then you have to manage budgets. And some folks like managing budgets, some folks don't. And so we have these discussions about influence versus authority. And so in each of these roles, it can change. The suggestion from one of the texts I wrote, which is actually really good, called the CMIO Survival Guide, published by HIMSS, talks about probably a direct relationship to the CIO with a dotted line relationship to the CMO, because the CMO in most hospitals has quite a bit of authority and definitely a lot of influence, because they're well respected by the medical staff, and you need that support of the medical staff when you do implementations. One of my friends that I talked to in discussion of this is that he's currently the CIO and CMIO for an institution. And the reason he felt like he's done that really well is that he was really well mentored. When he was a CMIO, he had a really good relationship with a CIO. And it's kind of needless to say, anytime you get any job, you want to develop good relationships and good rapport. And I'll talk in a moment a little bit about politics. Question? Yes?
Yeah, I can see the structure in a providing organization. Mm-hmm. Well, what about a systems integrator or a vendor? Do they have a CMO?
They may actually have a CMO, because what I've come to realize is some of the vendors, they use CMOs because they didn't feel that the CMIO, the I part of the CMI, was valid for that person. It was valid for me because I've done informatics, got some training, and it may be valid for a doc who's been working in healthcare IT for a long time and has that cred, but if they're a doc who comes in to help support a product without that technical background, so they will use a CMO. And sometimes folks, even in SMS, just call me the CMO without, just because they don't think about it. So, so some may have one or the other. I haven't seen any that had both. Because CMOs typically manage medical staffs. Other questions? And this is not an org chart. This is just connection. Org charts are a funny thing. Okay, so just a few things that key skills I thought were important for an effective CMIO. One is kind of core informatics roles, and I think it's being recognized. It is recognized by AMIA, and we'll talk a bit about the boards in a little bit. But having those core skills, and now that informatics fellowships are more readily available, and that knowledge through like AMIA's 10 by 10, the certificate program here and other institutions, that knowledge can be gained as opposed to being gained in the past through pure experience. As I noted in all three of the settings, strategy. The CMIO puts pieces together. As a clinician, understanding the environment, understanding the issues of Medicare, Medicaid, payers, how referrals are done, how you order a drug, those are all goes into that strategic thinking. So that when you I read a lot of trade web pages, healthcare IT news, the HIMSS, because you want to say, oh, something's coming down from ONC or meaningful use. You have to kind of pause and say, okay, what does that have to do with my company? If you're a mobile healthcare app developer, you better be aware that FDA is developing rules on certifying mobile applications. And if you're not thinking about that, you have to react as opposed to being able to provide that strategic thinking to your company. You have to provide leadership. You're leading groups of people, especially in the hospital, in implementation. So you have to understand how to work well in a team. I only half joking say, I think the old school physicians as the paternalistic do what I say is going by the wayside. Clinicians in general, at least for my aspect, and for CMIOs, you become the trusted advisor. So you have to be able to work on those skills, foster those skills so that you can demonstrate that you can hear the concerns of your peers and be able to respond to them. Good skills of good leadership. Communication is huge. Hopefully I'm demonstrating that okay right now. But a lot of what you do as a CMIO is to translate, to distill information from one setting to another setting. So your product developers aren't clinicians. They were asked, create a screen so I can order a drug. Okay, what does that mean? What does it mean to order a drug? Drug names, drug routes, timing, things like that. And that's where you have to be able to communicate workflow to the developers and to the technical folks. And you have to communicate some of the technical aspects to the clinicians. One great example, I worked on the LOINC. Everybody familiar with LOINC? Okay, hope so. Good. Clinical note titles for the VA. And as part of that, I took 3 sites' note titles, which were 200,000 note titles. 200,000. These are distinct note titles that people use to create actual instances of notes. These aren't actual instances of notes. And I broke them down and helped worked with LOINC to elaborate the axes, the author, setting, type of service. And so I went back, and we had a group of clinicians to try to walk through these and try to help them understand what the value of letting go of Dr. Nguyen's Blue Clinic note, which only means something to Dr. Nguyen, and if you know what the Blue Clinic is, to internal medicine, outpatient, progress note. That has value. But you have to communicate that value to the clinicians because they have their workflow. They do it well. It works for them. It works well for the care of their patient in front of them. But you have to learn how to communicate that to help them understand that it's now no longer you and your patient. It's you, your patient, their providers, other institutions that provide care, and how do we make that better so that we can provide better care in the big picture. So continuous self-education, that's actually huge. Because in my role, I find this to be the most challenging because there's standards to keep up on, standards development. There's regulation to keep up on. There are a myriad of different technologies to try to understand. And so I spend a fair amount of time getting questions from the operations staff about, can you help us understand this better? So I go and I read up on it and try to give them perspective on it. So, we're all adult learners, so you recognize that you need to continuously improve your knowledge. Yes, sir?
Where do you see the new board certification fitting into this?
The new, I'll move on here. Oh, shoot. I'll start. I think the board certification ultimate value is yet to be determined. However, my personal view is there's going to be value in it, but maybe not for 5 or 10 years, because as the recognition of the value of the CMIO increases, there'll be more opportunities for individuals to become CMIOs. But at larger institutions that have gone beyond the implementing an EHR, they're at the how do we use the EHR for research? How do we use it to improve patient quality? How do we become trend, cutting edge? That's the area where somebody who's either formally trained and or board certified, that's going to provide value. If you put me up against somebody who's doing this 20 years and I'm doing the 10 and I have a board certification, they'll probably go after somebody with a lot more experience. But if you take one of the reports I saw showed some distribution, and over the last 3 or 4 years, the age group, or CMIOs, that's grown the most is between 41 and 50. So it's still a relatively young group. And so I think that board certification, in the same way you have a board-certified cardiologist who heads the cardiology department, it stands to reason that if you're going to have a clinical informatics department, or you're going to have somebody who's board-certified. At least gives you some reassurance. So a couple of other things to consider. Compensation, I think in general, compensation for CMIOs is similar to the other kind of second-tier C-suite folks, the CIO, maybe not the CIO, but the CMO. CIOs tend to get paid a little bit more. There can be a fair amount of travel. I travel a lot in my role because my office in Salt Lake City is remote from our headquarters in McLean, Virginia, so I travel once a month to McLean, mainly to maintain relationships and be there. That's where the executives are, to have that face-to-face time. So you're not on conference calls all the time. But you have to consider travel to professional meetings like HIMSS or AMDIS, which is the Association of Medical Directors of Information Systems, which is kind of the CMIO's professional society. But if you're going to be involved in HL7, there can be potentially lots and lots of travel, and so you have to factor that into the work. Factoring in clinical time, as we have already discussed. The notion of influence versus authority. How CMIO's role has been implemented varies from institution to institution, and I think it varies depending on their level of comfort, their size, and such. And so there are CMIOs who lead a group of folks who report directly to them, and they do things like meaningful use reporting or working with the clinicians. And so you may have your own budget, and you have to direct folks, or where it started with me with SMS, I'm by myself. I report to the CEO and the executive VP, and I'm kind of at the side. So I always like to joke and say, I have no authority in this company, but I have some influence. And so where that is important is that when you don't have authority and you can't make things happen, you have to be a good communicator and collaborator, so that the executives or other folks that you have to work with who do have the authority to get things done understand the value of what the principles that you're trying to communicate. And really with any kind of executive, I don't know how many executives are in here, but with executive kind of jobs, there's culture. If you are a new CMIO and you happen to join a mid-sized rural hospital and the docs there have gone through a bad implementation, they're going to have a bad feel about informatics. And so you have to know that in advance and ask yourself, is this something I'm going to try to get myself into? Or if you're at a teaching hospital and you had a bad implementation, well, it's a little bit different because who bears the brunt of healthcare in a teaching hospital? The residents. And the residents rotate out every 3 years. You get a new batch, and so you have so how IT is viewed by the medical staff is really important. And if you don't have shared vision with the other executives, you could be at odds. And so kind of increasing your awareness of how to work in that environment is important. So I think support of the executive leadership is really key. Being at an institution where they recognize the value of health IT as a way of not only improving care, but ideally, improving the bottom line, which is a whole other discussion, but the value of health, of IT, and support of the community, and then expectation management. I have to say I'm doing an okay job with expectation management in my role, because I think some folks in the company, when they see I'm a doctor, I do informatics, oh, so you must know everything about medicine? And not only that, you know every kind of technology. And you have to say, no, I don't. But I'll work with you guys to understand that. You're part of a team. And Rob and I, he led the research and innovations. Now this is the CTO, and I'm building out a clinical informatics group in the company. I have my second reporting doc. And so we're looking at ways of working together so that we're mutually collaborating and not working at odds with one another. So where's the future? Well, I think there's going to be more CMIOs. There are a lot of hospitals out there, and there are a lot of them still using paper. And meaningful use and high tech are encouraging them to move to EHRs, and they're going to need some help. And so there's jobs out there for not only CMIOs, but clinical informaticists in general with this kind of expertise. You're going to have more responsibilities, I think, along with CMIO and CIO, being able to lead departments, making your decisions about how to improve patient care, and then trying to communicate with the leadership to get funding to do that type of work. Effectiveness through things like showing that the implementation of technology improves the bottom line, or at a minimum, should improve patient care. And then, where do these new technologies come in? The rural hospital isn't going to be looking at doing genomic medicine or predictive analytics, but at an institution like OHSU, a lot of data, a lot of knowledge, a lot of expertise. These are where this type of understanding and leadership is going to be important. And then we talked about the board certification. I think it's worthwhile. I'm going I fly to Philly on Friday to attend a 3-day board review course by Dr. Hirsch. So I'm convinced that it's important. I think it's a viable career course, and to the extent that you can plan it out, it's helpful. If I think being involved in implementation would be a very worthwhile experience if you ultimately think you want to be a CMIO, because there's a lot of it to be done, and not only is it first time kind of in implementation, but when hospitals say that was a terrible implementation, they rip it out and they want to put something else in, because I think that's going to be the next phase in the next 5 to 10 years, because as the younger doctors are coming through and have worked with CPRS and institutions of EHRs, we overcome the frustration aspect of technology implementation. I think any of you who are docs who've done training, you show up on day one at hospital A, and within 48 hours you figured out what you need to do with that system to get the work done. And then at the end of the month, you go to hospital B and you do it all over again. So adoption isn't going to be the issue. It's going to be expectation. And so they're going to be a lot more savvy and have much higher expectations for health IT in the future. So, questions, please. Yes. Go ahead. Oh, go ahead.
So, you were talking about physicians and other clinical people who sort of become CMIOs and then have to backfill on the informatics. That's sort of a common old story. Are there stories the other way where people have informatics background and not very much clinical experience who then have to learn more about hospitals and how they really work and whatnot? Or do you not? Is that pretty rare?
I don't have as many examples. I don't have actually. I'm trying to think of all of it. I don't have any examples of that. I think the majority have done the clinical work, and then enter into or have continued clinical work like me, and then entered into that role. It's really a challenge, and it's one of my personal fears about getting out of clinical medicine. Is that once you get out, they say that the medical knowledge doubles every 10 years. How do you get back in? I think having the informatics experience, you then, if you were going to look at the clinical scenarios, then you deal with you would have to have your subject matter experts. Because even as a CMIO and informaticist, I recognize that I'm a generalist. I don't know. I have familiarity with the ER workflow, and that's important. But there are probably details that I don't know. And so, if you don't have as extensive the clinical experience, you could get the subject matter experts. That wouldn't be that hard. Yes.
The only one I've ever known to do this is Paul Clayton. He was the CMIO of Intermountain Healthcare, and he was like, he's an informatics luminary, but he has a PhD, he doesn't have an MD, and he basically learned the clinical content so well from his subject matter experts that he could do that role. And I think he found it a challenge, a good challenge, but a challenge to engaging. So if you really want to be engaged with clinicians and work with them very closely and bring the informatics, close to them, then that's a role that, you should think about to see if, developing up to as an informatician.
Yeah. So just to follow up on that, do you see this changing, over the next? Maybe it's changing, maybe it's not with the clinical informatics subspecialty, but with informatics being seen as more recognized as a field and more training being accessible and more people being interested in doing this who may or may not have strong clinical backgrounds. Do you think that the clinical informatics subspecialty will sort of take over that area and block other people out of this kind of role?
Potentially it is, because I think that's one of the concerns that was raised at AMIA when they did when Dr. Hirsch was on the panel and they were discussing it. Is there are a couple of requirements for taking the clinical informatics board. One is that you hold a board certification in one of the ABMS boards. So if someone who's gone to informatics master's program or PhD program right after residency or after med school, because I know some have done it right after med school and didn't do any residency, they can't sit for one of those boards. And so where does that fit? And I think the answer is we don't know. Because, also that clinical informatics isn't available for nurses who have been practicing, who have PhDs and nursing informatics training. So where those all fit, I'm not sure yet. Yeah. So I think they hopefully they tackle this part first, and then figure out where to tackle the other part. Because I think having med school, an internship, of residency, you have core knowledge, but it's that broad knowledge I think is also valuable when you get out and practice it in the real world too. It's all a matter of experience, and we can't have all experience. That's why we rely on subject matter experts. Yes?
There's a lot of drivers that are bringing technology into health systems. what I don't see as much is the clinician point of view and the patient point of view and the view that we're actually delivering care here and into the technology development. It's very tech-oriented. And so when I look at vendors and I look at companies and I tend to look at, who's on our team. And sometimes there's a medical, expert. But a lot of times they have advisors. They have like clinician advisors or physician advisors. And so I wonder, I guess my question is really about where do you see the value beyond things like, implementation and things that you discuss in bringing the core business of what you're trying to do into the technology development and implementation?
Well, I think in the development part, I think it's valuable to have clinical informatics folks who practice working with the developers as they're developing the technology, whether it's an EMR or a device, because without that kind of experience, I think developers, whether they be software developers or technology, make presumptions about how it's going to be used. And so I think workflow is actually huge. And that's where the clinical experience gives you that. I think one of my favorite books I've read is called The Art of Innovation. It was published like 10 or 15 years ago, and it's about a company called IDEO. They helped, if you guys ever remember, the handspring was like the early Palm. They tell a story about going out to a cardiology suite at the hospital because they were helping a catheter manufacturer improve their catheter, and they were watching the cardiologist do the procedure and noticed that they always had to kind of twist a certain way because there was some issue with the catheter, and had they not observed that or recognized that or worked with the clinician, you start selling these, and cardiologists says, I'm not going to use it. It's too complicated or too wonky. And so I think in trying to answer your question, you need that. The clinical informatics is one of the groups of folks that are going to bring that workflow to the application because they bring that understanding.
No, I understand that, and I think everyone here understands that, but I find that sometimes it's the organizations and the companies that don't understand bringing in that clinical perspective and that user perspective is going to help them be more successful because it's more focused on the real world. And it really, again, I find it interesting that there's some of the biggest vendors. I'm at the VA, so I got to deal with a lot of vendors, okay? So, including you guys. So,
including us.
I just find it interesting that many of them don't have a clinician.
Yeah.
And I want, it's like, what is the problem here? What is the lack of understanding, and how can we help drive that recognition of the value? Because in the end, I think they're cutting themselves short.
I think one of it maybe they don't realize that that's available, that this kind of training is available. So it might be that part of it. As someone who has to talk to vendors, a reasonable question is, what is your clinical support in your developing your technology? That's a valid thing. And if they say, oh well, we have an advisory board, a lot of companies, instead of having a full-time clinical person, they have advisory boards, and I'm always wary about what does that mean. But maybe it's they take them to a retreat and show them the software, they have them review the software technology. But my role is to help bring that clinical perspective to at least the clinical contracts that we're looking at, so that the technical folks understand why is it that standard terminology is so important. I talk about that all the time with them, and meaningful use and those aspects. So I think maybe it's more education.
Well, I think from my perspective, it obviously helps us a lot. My background's all technical. So I've seen some of the workflows within the VA, which are enlightening. And I've had long discussions with Dr. V about the medical end of it, which is a piece I've never had in my career. So it's very useful from my perspective to gain that broad background. It helps me be a better generalist, helps me look at how we would better solution a product, how we would choose one technology over another.
Yeah, that's.
I think that's one of the issues, but the other issue is
14 vendors of.
for EHR systems. It's difficult enough to integrate 2 or 3 vendors together, but 14 vendors is going to be a challenge. I don't know what your thoughts are. That's.
Well, you're counting the 14, like the bigger ones. Yeah, with a myriad of smaller ones out there as well, who may or may not have the support they need to be able to meet meaningful use and that kind of compliance. My sense is that in 10 years, the strong will survive. But unfortunately, those who didn't buy one of those strong will have to figure out what to do in terms of ripping out the old system, putting in a new system, and that's a great area for clinical informatics. What do you do with the old data? How do you make that data available, useful? So I think there are lots of jobs available. One of the things is probably, depending on the community you work, where you want to work. We're fortunate in Salt Lake City that we have a pretty vibrant informatics community with Intermountain Healthcare, the University of Utah. Two of the universities, Utah Valley University and Weber State, are starting a health IT, and I'm participating in a health IT committee for the community college. So it's useful. So if you're willing to move, though, there does seem to be a lot of IT jobs. It's all part of the consideration. Other questions? Well, thank you very much. Oh, yes.
You mentioned the challenges of continuous education, and you mentioned healthcare IT news that you follow in HIMSS. Are there other things that you read regularly, or do you have a kind of a rigorous way of staying in touch, or is it more catch as catch can?
It's catch, yeah. It's when I can, and it's often problem focused, trying to gather information to help an understanding of a specific technology or such. So, well, thank you very much, everyone. Appreciate your time, your attention. Okay.